Hi, this is Dr. Bishai, and this is part 4 of our lecture on health insurance. And in this part of the lecture, we're going to be covering the role of groups in health insurance. And I've mentioned a little bit about why we care about having groups. We noticed that in the U.S., groups are employer-based groups. The employer is the one who forms the unit that gets health insurance in the USA. There is government-based health insurance. We'll cover both Medicaid and Medicare for seniors. Remember that Medicaid is for low-income Americans and Medicare is for seniors. There are individual markets still, and in the next few minutes we'll be thinking about what's going on in the individual market, and it should become obvious at the end of this short section why one would expect to see high premiums in an individual market for health insurance. If we look at the returns to scale, there's so many reasons why a group offers returns to scale. It offers the companies a way to invest way more money in financial markets more predictably. With an individual, it's so much more difficult to predict how much you'll have to pay out as an indemnity. And if your actual payout is greater than your predicted payout, you could go bankrupt. You could have all your money in stocks and bonds, and then you suddenly need to cover all of these individuals, and you couldn't predict their utilization as well. And if you get your prediction wrong and end up becoming less sick than you expected, you probably are carrying too much cash in your portfolio, and you should have been deeper into the riskier financial instruments. The larger the number of insured people, the easier it is going to be to make your prediction on your indemnity more precise. In general, the rule of thumb in the insurance industry is that you'll need to have about 10,000 covered lives to be competitive. If you're covering only a few thousand, 8,000, 9,000, you really don't have that law of large numbers giving you the precision to predict the net indemnity. And so that is some fundamental problem of the scale of the insurance market. Just to put more evidence that there are returns to scale, the loading charges go down with the number of workers in a firm. This short paper looked at the loading costs as a percent of the claims by the size of the number of workers in a firm. So for the largest firms with 500 to 2499 workers, the loading charge was 12%. For small firms with 1 to 4 workers, the loading charge is 40% of the cost of an insurance contract. So small businesses are more costly to insure. You've got to spend a lot more money servicing their claims, enrolling them, finding them, and attending to them. And this is money that is in the healthcare economy, but it doesn't do anything for health. All of these loading charges are being run to just keep insurance companies going. So if America had all of its insurance in small groups of 1 to 4, we would be spending 40% of America's healthcare budget, which is $3 trillion. That would all be going simply to run health insurance companies and would do nothing for making people healthy. It would be administration and financing and billing and coding. Returns to scale are pretty key in health insurance. Now, on average, we think that America's loading charge for the average of all of our employer-based costs is somewhere around the 20% range. We don't have enough Americans in the large firms. We don't have tons in the tiny, tiny firms. So when you see the American health economy at $3 trillion, 20% of that, $600 billion a year, is simply the cost of keeping our private health insurance industry going. And that's money that doesn't make us healthy. So premiums are lower for groups because there are returns to scale in marketing, because we can control adverse selection into the group, and that'll become obvious when I define what adverse selection is. Adverse selection is you wanting to buy insurance because you know how sick you're going to be. And in the individual market, very common for somebody to run into it if they think they're going to be sick. If they suddenly start having, bloody stool, they'll say, oh, I must have cancer, I better go get insurance. Or if they think they might be pregnant, they'll run in and buy individual health insurance. So adverse selection is a problem of selecting sick people in. And in groups, that's less likely to happen, but in individual markets it's quite common. And then finally we talked about the predictability of the indemnities due to the law of large numbers. Outside of groups, individual insurers were allowed to do medical underwriting. Medical underwriting means giving you a physical exam, finding out your pre-existing conditions. And the ACA outlawed medical underwriting and said it's not allowed to ask somebody coming for insurance whether they've had a pre-existing condition. The list of pre-existing conditions that you could be declined for is here on the slide. You'd be declined for AIDS, HIV, pregnancy, severe obesity, epilepsy. This actually left out a lot of Americans fell on the list of declinable conditions. Roughly 20% of Americans under 65 have a condition that makes them uninsurable. And for the last 10 years, this provision of guaranteed issue of health insurance has been the most popular provision of the Affordable Care Act. This was a real problem for a lot of people. It's something that people still remember and fear is developing one of these conditions and becoming uninsurable and not able to get a job because your employer won't hire you either if you can't get insurance. So if you think about it, if you go back to the list of conditions for competitive equilibrium in Rice and Unruh, being told that you can't buy a product is on the list, isn't it? We asked for non-excludable products. If we have a market where we say to people who want to trade goods and services, you cannot trade goods and services, that excludes them from the market. So fixing that market failure by saying people with pre-existing conditions cannot be turned away from the market solved that problem, but it also created a new problem for the insurance companies now who need to know how to insure people with these pre-existing conditions. So obviously the premiums are going to go up because of the provision to insure people with pre-existing conditions. But it's a level playing field, and all the insurance companies now have to play by the same rules. Last bit is for us to think about one provision of the Affordable Care Act was that guaranteed renewability. There were many, many provisions in it, and we'll talk about them later in the course. But if we look at the trajectory of America's uninsured population from 1964 onward, the biggest improvement in the number of uninsured Americans occurred after the creation of Medicare and Medicaid, where we covered 10% of the population with these two programs. But from 65 up until 2014, we really made no progress on insurance. 2 years after the Affordable Care Act took place, we were able to get the uninsurance prevalence in America down to about 9%. So the question is, we made these people better off. They took advantage of a voluntary opportunity to become insured, and they are definitely better off. However, if we ask the question of Pareto optimality, I'm pretty sure that the Republican House and Senate that voted dozens of times to repeal the law felt that even though these individuals were better off, their constituents were made worse off. And the constituents felt that they were being harmed by having to supply the tax dollars that helped to supplement the Medicaid expansions and the subsidies inside these insurance pools. So under the definition of Pareto optimality, the Affordable Care Act cannot be Pareto optimal because we actually find Americans who say, I was made worse off. We have to use other ethical criteria to ask, okay, it wasn't Pareto optimal, was it still worth doing for other purposes of justice and equality? Are those things that we could argue? This isn't an ethics class, but just showing that the Pareto optimality ruler does not let the Affordable Care Act measure up. So let's summarize. had a lecture on the demand for health insurance, and we've seen that insurance is a great thing, even though some people don't think they ever want to transfer money from their sick self to their healthy self. We met Walt from Indiana, who definitely doesn't want to do that. Most people are willing to pay to have less variation in their income and to have the privilege of sending money from our healthy selves to our sick selves. It's a service, and we have to pay for it, but luckily it's a service that we want and we value, and so very often we do pay for it. It's a service that is cheaper when it's bought by a group, and simply forming a group of people that want to buy insurance, that can be a Pareto optimal policy because there are returns to scale in that group. However, like any service, it is possible to have too much or too little. And we saw that it's possible for a society to be overinsured. They could find a place where the marginal cost of more coverage makes people use more things that aren't so valuable. And that cost goes up above the marginal benefit. So it's a tough problem. And we've got enough time to get together and think through what to do about the problems in the health insurance industry. So this is just an introduction. We have another month of work on all of the problems and difficulties facing our economy as we try to get this product of health insurance to wiggle out of all of its market failures. So thanks for joining me, and I look forward to discussing these issues with you more next time.